Good evening, everyone. My name is Dave Russell. I'm with Digestive and Liver Center of Florida. Tonight, we have a very interesting presentation put together by Dr. Juanita Patterson. She is our nutrition expert. She has been with the practice for many years. I won't say how many because that would probably date you, Juanita.
That would, just a little bit. I'm trying to fight that.
But Dr. Patterson has worked with our key partners, our senior partners in the firm now for a number of years. The presentation tonight was euphemistically termed by our digital marketing manager, Ellen Duran, who is listening in, as "It runs in the family." And tonight it's about irritable bowel syndrome. But there are a number of other features here, because I've gone through the presentation, that I think you'll find fascinating, whether you suffer from IBS or not. Dr. Juanita Patterson, over to you.
Okay, here we go. So I chose this topic because it seems to be such an enigma for the community, for patients, for families, and even for the GI providers when somebody is having some abdominal pain. And when I was a little girl, we used to call that a nervous stomach. I don't know if anybody remembers that. You know, your belly would hurt, you know, there would be no explanation. Everyone thought you were faking it. But I think we're past that. Now, I see sometimes there's confusion between irritable bowel syndrome and inflammatory bowel disease, and they're not the same entity at all. All right. So the inflammatory bowel disease is more considered an autoimmune disease process, where irritable is exactly what you think. It's irritable in one way or another. Some people have a combination of diarrhea with constipation and bloating. Some people have more of a constipation type. Some people have more of a diarrhea type. And I think that's why they called it spastic colon for a very, very long time. Now, unfortunately, we can't seem to really nail what's exactly causing it, though when you get further down into the presentation, there's some new thinking on this. So we can do some blood work, and we can do x-rays and CAT scans and MRIs, and even go and get the colonoscopy done. And a lot of times it tells us nothing, but it does exclude a lot. It excludes inflammatory bowel disease, for example. What we do know is often it's triggered by something, some kind of even just gastroenteritis, some other kind of health issue. And it doesn't have to just be physical. It can also be emotional. Now, in the past, and it's really unfortunate, they used to think this was all psychological. And what we've learned, like so many other of our health problems, that there's clearly a gut-brain connection, and there's physiological as well as the psychosocial factors. And I think we have to kind of bear that in mind when we're taking care of this group of patients. Clearly what we know is going on, there's some kind of alteration in how the gut works. And what seems to be, it hurts more for maybe a normal amount of gas. Our fancy word for that is visceral hyperalgesia. And so we're always looking at, you know, when you say it runs in the family, are there any genetic factors that are involved? Clearly some environmental factors, which also can run in families, as we know. So really what's going on is this heightened sensitivity to maybe a normal amount of gas. Maybe there's the nerve endings inside of the colon are different, or they become different. And it's pretty common. 1 in 7 people are thought to have this actually following some kind of other gastroenteritis problem. We talk about autonomic dysfunction, again, the gut-brain axis. And we kind of think that because we can't find a physiological abnormality all the time. And again, when we actually do a workup, it seems like the symptoms don't always correlate with what we find. Many times what we'll see is after somebody eats, they'll start to get this, you know, it may be a disconnect between how the stomach is and the colon are supposed to work. So if we eat food, our stomach distends a little bit. It's supposed to increase peristalsis in the colon, you know, the digestive tract, to push the remnants of food along. So eventually we have a bowel movement. And we think that might be some like stronger contractions that are happening, and this may increase some of the pain. Now, there are some things such as maybe some people find if they eat too much fat, this may increase the permeability of the colon and it makes them more sensitive. Later on, as I talk about something called the FODMAP diet, we find that even certain foods can be causing more sensitivity in the small intestine. Women definitely will know. Any woman who's had a menstrual cycle will say, gosh, my bowels seem to get all jacked up during my menstrual cycle. They'll have constipation, they have bloating for sure. They feel like they've got fluid retention. And there's also some rectal sensitivity, but we don't think it's the hormones themselves that are causing that. So it's kind of an interesting correlation. When we look at psychological factors, emotional distress and is definitely linked. And I wish I could just say we should all just be calm and carry on, but it's just not that easy, right? We see a lot of correlation with acute and chronic anxiety, depression, sleep disorders are often go hand in hand. And some people just express their stress through their digestive tract. They could seem calm as a cucumber on the outside, but it's the inside where something is actually happening. So when we're diagnosing any kind of GI problem, we always think, what is the age of the patient? A lot of different things happen at different ages. I mean, we can see a very young person or an older person, just by age alone, we start thinking of a different kind of health problem. Was there anything that actually triggered this event? And that's when if you have all this discomfort and you go to a doctor, think to yourself, okay, when was I normal last? When did everything feel okay? Was there anything that preceded that physically, emotionally? And getting that clinical history is very helpful because we have something called Rome criteria, which I'll show you in a little bit, that even without any kind of testing helps us get what we call a clue or a working diagnosis that it's irritable bowel disease and not an inflammatory bowel disease. You know, you want to look and think about, how does my bowel function? What are the timing of my bowel movements? When do I get my bowel movements? Is it immediately after I eat? Or is it normal in the morning? Do I have any vomiting that's going on with that as well? Clearly red flags are rectal bleeding, weight loss that you can't account for, having a fever, having more than 10 bowel movements a day would never be considered normal, right? So what we do is we do the basic lab test. A lot of times we do a colonoscopy. This is can be a diagnosis of exclusion, because what happens is we try and tell somebody, okay, based on this Rome criteria, you know, you have irritable bowel disease. We don't really need to do any more tests, but let's kind of lay out a plan. And that's hard to buy, right? Because you feel so bad. So often we wind up doing more diagnostic tests and invasive tests than maybe we would if it was ourselves, for example. Whenever someone's got abdominal pain, we think about, okay, what's going on? What do I think is really going on? So we think about, okay, is there laxative abuse? Is there a milk intolerance? Has some medication caused diarrhea or constipation? Have somebody had their gallbladder out? There's a typo there. It says it's supposed to be a small bacterial overgrowth. Did they catch some kind of bacterial or parasitic illness? Again, is it autoimmune, or do we have a microscopic colitis, or is it an early inflammatory bowel disease and it's not irritable at all, or maybe an underlying celiac disease where you can't have any gluten or you're gonna have diarrhea? Less common things, and I put this here and I'm not going to really cover it so much, but it's important to think that if you've had some kind of radiation in that area, you could have inflammation down there. If you have any kind of, if we see someone in the hospital, they've had a significant hypotensive event, you may not get enough blood flow to the colon, so we think of ischemic colitis. Maybe it's a malabsorption problem. If somebody's got chronic constipation, I've seen this more times than I can count. You know, people think, oh, it's just my usual constipation. They don't have a routine colonoscopy, and what is it? Instead, it's rectal cancer. So it really, if you can't figure it on your own and changing your diet doesn't make a difference, please go see the gastroenterologist and just get a workup done. Again, there could be just some severe thyroid problems that has caused hyperthyroidism can cause a lot of diarrhea. Hypothyroidism can cause severe constipation. In very weird cases, if you have so if we see someone who's got a lot of diarrhea and then we start thinking of all these kind of other things that are much, much less common, but you're going to be seeing a gastroenterologist by then, or maybe even in the hospital. So Rome criteria, this is someone who's had abdominal pain at least 1 day a week for at least 3 months. And they're going to have 2 out of 3 of the following: pain when you poop, pain that is associated with the frequency of going to the bathroom, pain associated with consistency of stool. So if you think about that and you fit the criteria, it does help with our workup. So when we know our office visits seem to be too fast, you know, all of our questions aren't answered all the time. But if I help teach you the things that we're looking for, you can come in with a really good history, and it's going to really help us a lot. Now, on physical exam, these people they tend to look healthy, except when you touch their tummy, it's tender. It might look a little bit bloated. To the individual, it looks really bloated because they know what they look like when they're not bloated. Often it's in the lower quadrant over the sigmoid area, but it doesn't meet the physical diagnosis of what we call diverticulitis or an acute abdominal process. Again, another typo, the rectal exam, that should be, we should do one on every patient at some point because you're looking to see if there's blood in the stool, which is never normal. Women should have their routine pelvic exam. We think of things like ovarian tumors. Do they have endometriosis? Some of these things can mimic irritable bowel syndrome. How do we test? Like I said, we do the Rome criteria. We get a really good history and physical. Then we do things like a complete blood count. We do a full chemistry panel, including all the salts, minerals, kidney function, liver function. If we think there's a family history of celiac disease or you meet other kinds of criteria, we'll probably order that workup. If diarrhea is really prevalent, and sometimes diarrhea isn't always prevalent in celiac disease. Calcium tests, thyroid tests, you know, if we're looking at constipation. So what kind of tests might we do? We might do a sigmoidoscopy or a full colonoscopy to really, you know, based on the clinical picture. Sometimes they'll inflate some air into the colon, which to see if we can trigger any kind of spasm. Biopsies are often done. It's less common in this situation to do an EGD, but if you're having upper abdominal pain, you can have coexisting problems. You can have gastritis, you can have duodenitis. Sometimes we have to check for fecal fat excretion. Now we have the stomach and we have the large intestine, but in between all that is the small intestine. So that's a whole nother workup of, sometimes we do a capsule endoscopy or an enteroscopy just to really maybe do biopsies and look and see what's going on. There's check for carbohydrate intolerance, or this whole new idea of small bowel bacterial overgrowth. And we talked about that in my last lecture quite a bit, of where there's a dysbiosis of the good bacteria in the mouth, the esophagus, the small intestine, the large intestine. So when we look for something else, you know, we're looking for new symptoms, right? You know, at some point you were normal. And so you think back, okay, what has happened? Do I have blood in my stool? Do I have diarrhea when I go to bed? Is there weight loss I can't account for? Is there fat in my stool? Am I sick? Do I have fever, chills, vomiting? Definitely if you're vomiting blood or pooping blood. What do my stools look like, smell like? And do you have to get up while you're sleeping and go to the bathroom? So when we talk about diet for irritable bowel syndrome, sometimes just changing, eating more slowly, drinking more water, maybe having portions that are not as large as maybe they used to be. Some foods cause more gas, and you can try Gas X. You can try, what I do is I use a pressure cooker. We know anyone who does any cooking that you can soak your beans and then rinse the beans a couple times, and then often cooking them, that helps degas the beans themselves. Again, coming to this idea that people can eat certain foods their whole life, and now they're having trouble eating these foods. We know that that is true. So historically fermented vegetables are really good for you. Sometimes people with irritable bowel syndrome, they don't tolerate it as well, and it's just uncomfortable. Any of the diet sodas, the diet products, you know, they can cause more bloating and more discomfort. So what do I think? I think if you want to sweeten something, sweeten it with a little bit of honey and stay away from the diet stuff. There are a lot of things that can be helpful in terms of bananas, grapes, sometimes, you know, can be helpful. And sometimes some people find that it causes bloating. So paying attention to what you're eating, maybe doing a food diary, maybe doing an elimination diet can be helpful. Lactose is more common than what people think. Gluten sensitivities are more common than what people think. Having just gotten back from Spain and spent a day in France, the quality of the food is spectacular. And I've had too many people go to Western Europe and say, you know what, I can't eat these foods here in the United States, but you know what, I can eat anything I want. I can have all the croissants in the world. when I'm out of the country. Now, try a low FODMAP diet. And I've actually got the link, and I went to the trouble to, so you don't have to do it, of just showing how many foods that you might be sensitive to, what kind of foods do they recommend. I've had patients in my practice where they've been everywhere. They've seen everybody. And it wasn't until they just really focused themselves on their diet and what things were triggering their problems did they really start to feel better. Now, there is a company called Cell Science, and they do a test called an ALCAT test, and it's looking at food sensitivities, not allergies. None of those tests are covered by insurance, but you can definitely go to their website, read about it. A lot of their research is partnered with Yale, technically a reproducible test. And in the red column, those are foods you're sensitive to. You stay away for 6 months. In the yellow column, in the orange column, you stay away for 3 months. In the yellow column, you might stay away from a month. It talks about, you know, sensitivities to gluten and sensitivities to dairy. And it's easy to focus on what we can't have. But I want you to really think about, let's focus on the things I can have. And the FODMAP diet does do that pretty well. Now, sometimes just changing the fiber in our diet can help a lot. You know, you can look at just even raw bran. Some people like to maybe make their own homemade bran muffins. There's definitely bran cereals. We know Benefiber is a prebiotic. We know that Metamucil is psyllium husk. And you just have to always start with a little bit at a time. I don't ever follow the instructions on either one of those. You start with a little bit and see how you respond as an individual. And I think that's really important because too much of anything can cause gas, diarrhea, bloating, constipation. So just ease your way into that. Now, I'm not really covering the medications for irritable bowel disease. We do know, and all of my references, by the way, from Merck Manual, I just focused on that because it was so comprehensive in laying all this out as a lecture for us. Many people, they just take too much Pepto-Bismol, or they'll take a lot of Imodium over the counter because they want to get on a plane and they don't know what else to do. And I get that. You know, for people who just have so much constipation in spite of everything they do and the workup has been done, there are some prescription medicines that can really help normalize the stool. And once you're on them, you're technically thought to stay on them forever. Polyethylene glycol is Miralax. It does seem to be helpful for the constipation type, but again, you may not need the whole amount. You may need half amount. You know, sometimes we use some prescription antispasmodics. Stool softeners by themselves don't seem to help a lot because it's just not a stool softener problem, right? And if, you know, maybe in another lecture, if we want to, you know, really go into some of the prescription medicines, but you're going to be seeing the GI docs. I don't really want to waste all your time on this. Now, like I said, all my references for this, I want to give all the credit to the Merck Manual. There's a kind of a rule of thumb in medicine that if you memorize the Merck Manual, you can pass your internal medicine board. It's that good and it's updated that often. And there's an app for that now. And I love my Merck. It's called Merck Pro as an app. I love it. So we're going to cover the FODMAP diet, foods to eat. Look at this website, ibsdiets.org. That's where I went to kind of outline the FODMAP diet. It's pretty comprehensive. I did not include everything on this website. I tried to cherry pick a little bit. So vegetables, so we're going to focus on the things you can eat. I do cover the things that you don't eat, but I want to cover the things you can eat. So think of things that are easy to digest. Some people like alfalfa sprouts, bamboo shoots, bean sprouts. Some people do fine with Brussels sprouts, butternut squash, cooked cabbage, carrot, celery, cucumber. These things are often easier for people to digest, but not always. So you really have to think about, for myself, and you've heard me say this before, I make a lot of soups and I'm looking at a lot of these ingredients and they often just go into my soups. Some people do fine with lettuce of many kinds and some people don't. Often if you feel like your gut's all jacked up and it's all bloated, I always suggest, I say this to the hospital over and over again, even if somebody's had an inflammatory bowel reaction or they've had a colitis, I just say ease back into your diet very carefully. You know, you've got inflammation, there's microscopic damage that we just can't see with our eyeballs, right? So think of vegetable soups because those are cooked. Think of oatmeal, think of cooked fruit. Think of fish is much easier to digest than chicken or pork or red meat for sure. There is a expert who has written a book, and he has a concept called, let me see, it's called The Plant Paradox. So fruits we can think about eating. Most people know if they have diarrhea, bananas, rice, apples, toast. That's part of the easier way back into eating if there's diarrhea. Some blueberries, cantaloupe, coconut, for example, is easier sometimes than just a cow's milk. Melon is easier to digest. Papaya, cooked rhubarb, tangelos, clementines. A lot of people who, and this kind of surprises me, that they do better with small amounts of proteins. Now, if there are other people who don't do well with these animal proteins at all, so you have to figure out where you kind of fit into all of this. But based on the FODMAP diet, people do better on beef, they do better on fish, they do better on shrimp, staying away from some of the cold cuts, and even do okay on prosciutto. So some of this is pretty surprising to me. Now, even there's grains and cereals and breads. We find that wheat bread, staying away from that is okay. Sometimes wheat-free bread, people do okay. Corn and rice, maybe spelt, sometimes sourdough, sometimes not. Sometimes people find they can eat some nuts, but not all nuts. It just is really interesting. But again, people do really well on hemp seeds and chia seeds. Walnuts seem to be very well tolerated. Eggs, butter, real foods, right? Real foods. We're talking real foods here. Some of the harder cheeses are better tolerated. Sorbet over an ice cream. Greek yogurt, coconut yogurt over maybe a cow's milk. Things not to eat. And I didn't want to focus on that, but because it seems so controversial, because when you're thinking of restoring your good bacteria and prebiotics for your colon, garlic and onions are great prebiotics, but there are people that they don't do well on garlic and onions. Some people don't do well on asparagus. Some people don't do well on a certain kind of beans or cauliflower or a lot of celery, but maybe a little celery is okay for them. Some people don't do well with, like I said, fermented foods. They don't do well with falafel. Again, leeks, different kind of bulbs, mixed vegetables. And then again, you think about, some people have trouble with mushrooms, which in generally mushrooms are really well tolerated. Again, apples are considered something easy to digest, and yet some of these people, they really struggle with some of these kind of fruits. Then you think of other kind of fruits. Watermelon, where usually we know too much watermelon is going to cause diarrhea. You eat too much of a lot of these foods, it's going to cause diarrhea. So maybe that the portion is an issue with you. Again, things to avoid: sausages, because garlic is an issue. It might be one of the anything that's combined like a sausage or different kind, like I don't even know, it's the chorizo. I can't pronounce it, but I do like it. Again, same thing: couscous, gnocchi, muesli, pistachios. Some of these foods are just not tolerated very well. Again, wheat-containing products, certain breads, if they are muffins, anything with wheat or even wheat germs. Sometimes almond meal, but other times almond meal is good. It's really, I can see why this is so confusing for individuals, but remember, we're all a case study of one, and we have to figure out for ourselves. Now, I'm in the camp that organic food has more antioxidants in it. Organic food may be better for some people. I mean, we're always adapting to genetically modified foods. There are more and more of them. As our digestive system adapts, some people tolerate them. I don't think there's a group of people that don't tolerate these. So you have to kind of look and see where you fall. I think that might be a duplicate slide. Often a lot of the dips and the sweeteners are just too sweet for people. Anything with fructose and molasses. Honey can be too much for people. Again, I still think that might be a little bit quantity, but you'll have to trial and error and see how you do on that. Ricotta cheese, buttermilk, kefir, which is generally considered a fermented milk, is often really good for individuals, but for some people who have irritable bowel, it doesn't sit well with their digestive tract. Anyway, that's really all I have for today. Does anyone have any questions?